Hello there. So last time we were studying about reactive arthritis, and now let's move to the next scenario in rheumatology. Next, we have a 60-year-old man presenting with a spontaneous painful swelling of his right knee, which appears hot, very tender on touching. The swelling becomes worse over the last few days, and about a week ago, he had an inguinal hernia repaired as a day case. His regular medications include Ramipril 10 mg daily, Bendroflumethiazide 2.5 mg daily, glyceryl trinitrate tablets when required. He's apyrexial on examination. What is the single best method for confirming the diagnosis in this case? So, Bendroflumethiazide is a thiazide diuretic which is well known to cause symptomatic hyperuricemia, which can precipitate an attack of gout. And other common thiazide diuretics to be aware of include indapamide. So we have to remember about bendroflumethiazide and indapamide. These are thiazide diuretics which are known to cause symptomatic hyperuricemia, which can precipitate an attack of gout. Now, although a raised serum uric acid level is an important risk factor for gout, the use of serum uric acid as a diagnostic test is limited because during acute gout, serum uric acid levels can be normal. On the other hand, patients with hyperuricemia may never develop an attack, so that is also a possibility. So we have to remember that uric acid levels can be falsely low during an attack and should not be measured until about 4 weeks after an acute attack. It is only that time we will find those serum uric acid levels to be raised. Now, in summary, you may sometimes see a raised serum uric acid level in acute gout. However, not all people suffering from gout demonstrate raised serum uric acid levels, and this is not an accurate test to diagnose the condition. The gold standard is still aspiration of synovial fluid, that is joint aspirate, and detection of crystals on microscopy. Although aspiration of synovial fluid is the gold standard, but it is rarely done. This can be difficult and painful, and one needs to remember that majority of the gout cases are diagnosed in GP clinics where time is of the essence. Also, false negative results can be seen if the sample takes too long to reach the lab, which can be an issue for certain GP clinics. So again, bendroflumethiazide and indapamide, these are thiazide diuretics which are well known to cause symptomatic hyperuricemia, which can precipitate an acute attack of gout. So we have to be aware of these thiazide diuretics because they have tendency to cause gout. Now, although a raised serum uric acid level is an important risk factor in gout, but use of this serum uric acid as a diagnostic test in gout is limited because serum uric acid levels can be normal during acute gout. On the other hand, sometimes patients with hyperuricemia may never develop an attack. So serum uric acid levels can be falsely low or even normal during an attack, during an acute attack of gout, and they should not be measured until 4 weeks after an acute attack. In summary, we may sometimes see a raised serum uric acid level in acute gout. However, not all people suffering from gout demonstrate raised serum uric acid level, and this is not an accurate test. The gold standard test is aspiration of synovial fluid or joint aspirate examination. So that is aspiration of synovial fluid and detection of crystals on microscopy. Aspiration of synovial fluid and detection of crystals on microscopy. This is the gold standard. Joint aspirate and detection of crystals on microscopy. Although this is the gold standard, it is rarely done. It can be difficult and painful, and also most of these gout cases are diagnosed in GP clinics where time is of the essence, and false negative results can also be seen if the sample takes too long to reach the lab, so which can be an issue for certain GP clinics. So joint aspirate for microscopy or aspiration of synovial fluid and detection of crystals on microscopy. This is the gold standard, single best method or gold standard for confirming the diagnosis of gout. Let's move ahead. And yes, another thing which we should remember is in gout, we detect uric acid crystals which have negative birefringence. Uh, and In pseudo gout, we check for calcium phosphate crystals which have positive birefringence. And it is mostly affecting the knee, which is the most common area involved. Okay, so let's move ahead. Next, a 33-year-old lady who has recently given birth presents with pain in the base of her thumb. The pain is worse on movements. The pain is particularly felt when she picks up her baby or while changing the diapers. What is the single most likely diagnosis in this case? So this is a case of decurvance tenosynovitis, and decurvance tenosynovitis is seen here where there is pain at the radial side of the wrist, that is towards the thumb, at the thumb side of the wrist, and impaired function of wrist and hand. It occurs due to repetitive stress, and it commonly occurs in women during pregnancy due to the way in which the baby is lifted and held. So in decurvance tenosynovitis, there is pain at the thumb side of the wrist or the radial side of the wrist, and there is impaired function of wrist and hand, and it occurs due to repetitive stress. It commonly occurs in women following pregnancy due to the way the baby is lifted and held. Let's study a little more about decurvance tenosynovitis. So decurvance tenosynovitis, it is also known as washerwoman's sprain or mummy thumb and gamer's thumb. It is caused by the inflammation of the extensor pollicis brevis and abductor pollicis longus due to repetitive stress injury. So the two muscles which are affected here or which are responsible for causing decurvance tenosynovitis are there is inflammation of extensor pollicis brevis and abductor pollicis longus due to repetitive stress injury. So decurvance tenosynovitis, also called as mummy thumb, gamer's thumb, or washerwoman's sprain. It is caused by the inflammation of extensor pollicis brevis and abductor pollicis longus due to repetitive stress injury. The signs include pain over the thumb side or radial side of the wrist. The pain becomes worse on movement. There are two helpful tests which are used to diagnose decurvance tenosynovitis. First is Finkelstein's test. Second is Fickoff's test. Eichhoff test. Eichhoff test and Finkelstein test. Now, Finkelstein's test, the examiner grasps the thumb of the patient and ulnar deviates the hand. The examiner grasps the thumb of the patient and ulnar deviates the hand. Eichhoff's test, the thumb is gripped by the palm of the patient and the examiner ulnar deviates the hand. Many people mistake Eichhoff's test for Finkelstein's test as they are so similar. The tests are positive if the patient describes pain at the tip of the styloid process, which is seen here. There's a picture depicting which we can see the styloid process towards the radial side, towards the thumb side of the wrist. So, if the patient is complaining of pain at the tip of the styloid process, then this test, Finkelstein's test and Eichhoff's test, both are said to be positive. So, talking about decurvent tenosynovitis, decurvent tenosynovitis, also called as washerwoman's sprain or mummy thumb or gamer's thumb, it is caused due to inflammation of extensor pollicis brevis and abductor pollicis longus due to repetitive stress injury. And the signs include feeling pain over the thumb side or the radial side of the wrist, and the pain becomes worse on movements. The two helpful tests used to diagnose decurvent tenosynovitis are: first is Finkelstein's test, second is Eichhoff's test. Finkelstein's test, the examiner grasps the thumb of the patient and ulnar deviates the hand. Second is Eichhoff's test, in which the thumb is gripped by the palm of the patient himself or herself, and the examiner ulnar deviates the hand. So these both tests are almost similar, and the tests are said to be positive if during ulnar deviation of the hand the patient complains of pain over the tip of the styloid process that is present towards the radial side or the thumb side of the wrist. Let's go through the chart given here. So decurvent disease or decurvent tenosynovitis. It is tenosynovitis of extensor pollicis brevis and abductor pollicis longus involved in the movement of the thumb. Presentation is pain and swelling at the radial side or thumb side of the wrist. Risk factors are pregnancy, repetitive movements, rheumatic disease. So three risk factors are there: pregnancy, rheumatic disease, and repetitive movements. Treatment is rest and finger splinting, NSAIDs, and local steroid injection. So rest and finger splinting, NSAIDs, and local steroid injections. So this decurvent tenosynovitis should not be confused with decurvent thyroiditis or subacute thyroiditis, which is caused by viral infection causing hyperthyroidism and tenderness of thyroid gland. So yes, tenosynovitis affecting extensor pollicis brevis and abductor pollicis longus involved in the movement of the thumb. There is pain and swelling at the radial side or the thumb side of the wrist. Risk factors are pregnancy, repetitive movements, and rheumatic disease. Treatment is rest and finger splinting, NSAIDs, and local steroid injections. Okay, so now let's move ahead. Next, a 48-year-old woman with a history of rheumatoid arthritis complaining of dry eyes. A Schirmer's test shows decreased tear production, and Rose Bengal stain documents corneal ulceration. What is the single most likely diagnosis in this case? Now, this is a case of Sjogren's syndrome. Let's see if we have a chart on this. So, Sjogren's syndrome is an autoimmune disorder affecting exocrine glands resulting in dry mucosal surfaces. Sjogren's syndrome may be seen alone, primary, or in association with other autoimmune diseases, which is secondary, such as rheumatoid arthritis, primary biliary cirrhosis, or systemic lupus erythematosus. As Sjogren's syndrome progresses, it becomes a systemic disease involving major organs like kidneys and lungs. It may eventually involve It may eventually evolve into a lymphoproliferative disease, that is malignant lymphoma. Note that Sjogren's syndrome is much more common in females. The ratio is 9:1, female to male. Now, features are dry eyes, dry mouth, vaginal dryness, parotid enlargement. Dry eyes, that is keratoconjunctivitis sicca. Patient complains of itchy eyes, sandy feeling under their eyes because of decreased lacrimal production. Dry mouth, the patient may complain of difficulty swallowing food, and there is vaginal dryness and parotid enlargement, that is bilateral enlargement of the parotid glands. So these are the four features. Dry eyes, that is keratoconjunctivitis sicca, patient complaining of itchy eyes, sandy feeling under their eyes because of decreased lacrimal production. Dry mouth, complaining of difficulty in swallowing food, and vaginal dryness and parotid enlargement, that is bilateral enlargement of parotid glands. Investigation: in Sjogren's syndrome, we will use Schirmer's test, which will show decreased tear production. Second, Rose Bengal stain, which document corneal ulceration. Third, ANAs will be positive, specifically anti-RO and anti-LA. So, anti-nuclear antibodies. So, ANAs will be positive, specifically anti-RO and anti-LA. Rheumatoid factor positive in nearly 100% of patients. So, rheumatoid factor is also positive here in Sjogren's syndrome. Rheumatoid factor is positive in nearly 100% of the patients of Sjogren's syndrome. Management: there is no cure for Sjogren's syndrome. Artificial tears may help with dry eyes. So, Sjogren's syndrome, it is an autoimmune disorder affecting exocrine glands. It is an autoimmune disorder affecting exocrine glands resulting in dry mucosal surfaces. Autoimmune disorder affecting exocrine glands resulting in dry mucosal surfaces. It may be seen either alone as a primary disease or as a primary condition, or in association with other autoimmune conditions. So, in secondary forms such as rheumatoid arthritis, systemic lupus erythematosus, or primary biliary cirrhosis. As Sjogren's syndrome progresses, it becomes a systemic disease and may involve major organs like lungs and kidneys. It may eventually evolve into a lymphoproliferative disease, that is malignant lymphoma. Note that Sjogren's syndrome is much more common in females as compared to males, 9:1 ratio, female to male. Features are dry eyes, dry mouth, dry vagina, and parotid enlargement. Dry eyes, that is keratoconjunctivitis sicca, patient complaining of itchy eyes, sandy feeling under their eyes because of decreased lacrimal production. Second, dry mouth, patient complaining of difficulty in swallowing food. Then vaginal dryness, then parotid enlargement, bilateral enlargement of parotid glands. These are the four features. Investigation for Sjogren's syndrome: Schirmer's test, which is used to detect decreased tear production. Schirmer's test, Schirmer's eye test, showing which shows decreased tear production. Second, Rose Bengal staining, which shows corneal ulcerations. Then ANAs will also be positive, especially anti-RO and anti-LA, and rheumatoid factor is positive in 100% of the patients of Sjogren's syndrome. Management: there is no specific cure for Sjogren's syndrome, but artificial tears can be helpful for dry eyes. Now we have a chart on this as well. So Sjogren's syndrome, autoimmune disorder affecting exocrine glands resulting in dry mucosal surfaces, we already studied. Presentation, enlargement of presentation is dry eyes, dry mouth, vaginal dryness, enlargement of parotid glands and lacrimal glands. So enlargement of parotid and lacrimal glands, dry eyes, sandy feeling under the eyes, dry mouth, difficulty in swallowing, associated with rheumatoid arthritis, systemic lupus erythematosus, and primary biliary cirrhosis. Scleroderma. Investigations: Schirmer's eye test, decreased tear production, then rose Bengal staining indicating corneal ulceration. Then ANAs are positive anti-RO and anti-LA antibodies, rheumatoid factor, which is positive in 100% of the cases, and ANA. Management is by artificial tears and plenty of water and artificial saliva. So, swollen parotid glands, swollen lacrimal glands, dry eyes, dry mouth. Autoimmune disorder affecting exocrine glands, dry eyes, dry mouth, vaginal dryness, enlargement of parotid gland and lacrimal glands, sandy feeling under the eyes, difficulty in swallowing of the food, and associated with rheumatoid arthritis, systemic lupus erythematosus, primary biliary cirrhosis, scleroderma. Investigation: Schirmer's test showing decreased tear production, Rose Bengal stain showing corneal ulceration, ANA antibodies, ANA are positive, anti-RO and anti-LA, then rheumatoid factor is positive in 100% of the patients. Management is by artificial tears, artificial saliva, plenty of water. Next, a 78-year-old woman who is referred to who is referred by her general practitioner to the hospital with 3-day history of unilateral headache and pain on chewing. So, this 78-year-old woman has been referred by a general practitioner with a 3-day history of unilateral headache and pain on chewing. Her ESR is 70. She was subsequently started on high dose oral steroids, discharged to her general practitioner. What is the single most appropriate additional treatment? Now, this elderly lady with giant cell arthritis or temporal arthritis is getting high dose steroid, which can lead to demineralization, osteopenia, or osteoporosis. So, to prevent this, we have to give bisphosphonates as an additional treatment. Diagnosis here is clear: she has got temporal arthritis. Now, in these situations, the question writers always ask which medication could be added into the current regimen. There are two things that one can think of. First, bisphosphonates, which are important, can be considered to add on to reduce the risk of osteoporosis, especially in elderly females. Second is low dose aspirin. Low dose aspirin is also increasingly being recommended for people with a history of giant cell arthritis. It is found to decrease the rate of vision loss and also reduce the risk of strokes in patients with giant cell arthritis or temporal arthritis. A low dose aspirin is not given in the options here, so bisphosphonates would be the pick. So this we have to remember that in case of giant cell arthritis or temporal arthritis, bisphosphonates have to be given as an additional treatment to prevent the risk of osteoporosis, osteopenia, or demineralization, because this elderly lady with giant cell arthritis is getting high dose of steroids, which can cause demineralization, osteopenia, osteoporosis. So to prevent this, bisphosphonates are given. Now, bisphosphonates are important, can be considered to reduce the risk of osteoporosis, especially in elderly females. Another thing which we can add is low dose aspirin. Low dose aspirin is also increasingly being recommended, and in patients with giant cell arthritis or temporal arthritis, it reduces the rate of vision loss and it also reduces the risk of ischemic strokes in patients So here, because low dose aspirin was not in the option, so bisphosphonates would be the answer. Let's move ahead. Next, 59-year-old male is in the ICU, is in the CCU, cardiac care unit, and he suffered from myocardial infarction 2 days ago, which is now complicated by cardiac failure. He has now developed sudden onset of pain, redness, swelling of his right knee joint. What is the single best method for confirming the diagnosis of his swollen knee joint? Now they are asking single best method. Again, this 59-year-old male is in the cardiac care unit. He suffered MI 2 days ago, now complicated by cardiac failure. Now he has developed sudden onset of pain, redness and swelling in the right knee joint. Single best method for confirming the diagnosis of his swollen knee joint. So, joint aspirate for microscopy. So this is a multi-step question. We have to break it down. First, the man has had myocardial infarction. Second, he is now suffering from heart failure. Third, he is also suffering from a red swollen knee joint. By mentioning that the man has heart failure, they are pointing towards the fact that the patient is probably put on a diuretic during his stay in the hospital. Patient is, obviously there is fluid overload, so patient is put on a diuretic during his stay in the hospital, and these diuretics, uh, especially loop diuretics like furosemide, these are used as first line for cardiac failure. A thiazide diuretic may be added to a loop diuretic in case of severe cardiac failure. We do not know what type of diuretic this man has been put, but it is highly probable that he was put on a thiazide diuretic. In order to diagnose gout, now because these thiazide diuretics can precipitate hyperuricemia leading to gout, in order to diagnose gout, we must do a joint aspirate. Since there was no mention of this man having fever, because there is no history of fever, therefore there is no need to do a joint aspirate culture. Because there is no fever, no need to do joint aspirate culture. Joint aspirate microscopy would be the ideal way to go, since we would be able to visualize the crystals, MSU crystals of gout. You may sometimes see a raised serum uric acid level in acute gout, but not all people suffering from gout demonstrate raised serum uric acid levels, so not an accurate test to diagnose the condition. So we have to keep in mind, whenever the question says single best method for confirming the diagnosis, it is always a biopsy. It is always a biopsy or an equivalent of an invasive diagnostic test, because single best method is the gold standard method for confirming the diagnosis. It is always a biopsy or the equivalent of an invasive diagnostic test. So most common type of thiazide diuretics which are used are benflumethiazide and indapamide. Now, common or serious possible side effects of thiazides include hyperglycemia, increase in uric acid levels, hypokalemia, hyponatremia, hypomagnesemia, hypercalcemia, and postural hypotension. So these thiazide diuretics like benflumethiazide and indapamide, apart from causing hyperuricemia, they can also cause hypokalemia, hyponatremia, hypercalcemia, hypomagnesemia, hyperglycemia, and hypotension. They can cause hyperuricemia and hyperglycemia, hypercalcemia, and hypokalemia, hyponatremia, and hypomagnesemia, and hypotension. So this is about this case. Because this patient had myocardial infarction, he later on developed heart failure, so that is pointing towards probability that this patient might be put on diuretics, loop diuretics like furosemide, or even thiazide diuretics like benroflumethiazide and indapamide, which can precipitate hyperuricemia. So we have to diagnose if this patient is having gout or not. In order to do that, joint aspirate or analysis of synovial fluid for microscopy and culture is important. It is a gold standard, most suitable method or single best method for confirming the diagnosis. So, but because this patient is not having any fever, so we will not do culture. We will just use joint aspirate for microscopy and detect the presence of MSU crystals of gout. Raised serum uric acid level is not an accurate test to diagnose the condition. Now, another thing which we have to remember, benroflumethiazide and indapamide, commonly used thiazide diuretics, their effects or their possible side effects, we should say, are hyperuricemia, hyperglycemia, hypercalcemia, hypokalemia, hyponatremia, hypomagnesemia, and postural hypotension. Next, we have a 55-year-old accountant presenting to the GP surgery with a spontaneous, painful swelling of his right index finger. The swelling started 3 days ago, has worsened. He's apyrexial on examination. Now, a picture is given of his ring finger. There is increased warmth on the affected joint, and he had similar milder episode on that joint 6 years ago with joint stiffness which resolved by itself, and he takes benroflumethiazide for his high blood pressure. What is the single most likely diagnosis in this case? Now, this clearly tells this patient is taking benroflumethiazide, which is thiazide diuretic, which is well known to cause symptomatic hyperuricemia, which can precipitate an acute attack of gout. Other common thiazide diuretics to be aware of include indapamide, chlorthalidone, and metolazone. So benroflumethiazide and indapamide, then chlorthalidone and metolazone. Chlorthalidone, metolazone. Benroflumethiazide, indapamide, chlorthalidone, and metolazone. These are the four common thiazide diuretics which we have to be aware of, as they can precipitate an acute attack of gout because they cause symptomatic hyperuricemia, hence they can cause an acute attack of gout. The red swollen joint is a gout tophus on his finger. So this red swollen joint uh, is a gout tophus on the finger. One of the distractors here is osteoarthritis. Haberden's nodes are typically bony lumps in the joints as a result of osteoarthritis. These Haberden's nodes tend to develop at the distal interphalangeal joints like this question, but they do not become inflamed so acutely. They do not become inflamed like within a matter of few days, like over 3 days. Also, once a Haberden's node forms, it sticks around for good. The case above had an episode which was similar 6 years ago, but it resolved on its own, which is not a case in Haberden's nodes. So it is unlikely to be a case of osteoarthritis, and also it is unlikely to be septic arthritis in the absence of a fever. Now, another differential is herpetic Whitlow. Herpetic Whitlow is a good differential, but less of an appropriate answer because there is usually a break in the skin which allows the virus to enter in case of herpetic Whitlow. Vesicles are formed in the distal phalanx as opposed to inflammation of the distal interphalangeal joint. Herpetic Whitlow is seen more in dentists, nurses, or children who suck their fingers because they are in contact with lips, which may shed the virus. Now, while gout usually occurs in the metatarsophalangeal joint, any joint can be affected. Do not get misled because the joint affected is a distal interphalangeal joint. Gout typhi, gout tophi, tophus or tophi, gout tophi can develop on distal interphalangeal joints as well. So again, the important thiazide diuretics commonly used ones which we have to be careful about are bendroflumethiazide, indapamide, chlorthalidone, metolazone. Because these thiazide diuretics have tendency to cause hyperuricemia, symptomatic hyperuricemia, and can precipitate an acute attack of gout. Red swollen joint, here is gout tophus on his finger, and the distractors or differentials can be osteoarthritis, septic arthritis, herpetic Whitlow, etc. Why it is not osteoarthritis? Because in osteoarthritis we will see Haberden's nodes, which are typically bony lumps in the joints as a result of osteoarthritis. These Haberden's nodes tends to develop at the distal interphalangeal joints, like in this question, but they do not become inflamed so quickly, so acutely, within a matter of few days, like 3 days. And also, once a Haberden's node is formed, it stays for a longer period of time. In this case, the patient had an episode 6 years ago which resolved on its own, which usually does not happen with Haberden's nodes. It is also not a case of septic arthritis because there is absence of fever. Herpetic Whitlow is a good differential, but not an appropriate answer because in this there is usually a break in the skin which allows the virus to enter. And vesicles are formed in the distal phalanx as opposed to inflammation in the distal interphalangeal joint. Herpetic Whitlow is seen more commonly in nurses, dentists, or children who suck their fingers because they are in contact with the lips, which may shed the virus. So, while gout usually occurs in the metatarsophalangeal joint, other joints can be affected as well. So, joint affected here is a distal interphalangeal joint, and gout tophi or gout tophus can develop on distal interphalangeal joints as well. Let's move ahead. A 44-year-old woman complaining of fatigue over the past few months. She has had intermittent joint pains in both hands over the past year, often with morning stiffness. In the past, she has been investigated for microscopic hematuria and proteinuria. Her blood results are significant for positive ANA, negative ANCA, raised ESR. What is the single most likely diagnosis in this case? So the patient is having complaint of fatigue and intermittent joint pain in both hands over the past year with morning stiffness as well, investigated for microscopic hematuria and proteinuria. Blood results are significant for positive ANA, negative ANCA, and a raised ESR. So this is a case of systemic lupus erythematosus, and we have to remember not all the patients will have that classic discoidal or classic butterfly rash over the nasal bridge and malar bones. Classic malar butterfly rash over the nasal bridge or malar bones. Only half of them usually present that way. Morning stiffness and polyarticular symmetrical arthralgia is often seen in patients with systemic lupus erythematosus. Fatigue and tiredness are common features. In this question, the patient also presents with glomerulonephritis. ANCAs are associated with small vessel vasculitis, including Wegener's granulomatosis, sometimes even Church-Strauss syndrome. The absence of ANCA cannot indicate the absence of disease, but it gives us a clue of which are the less likely options in this question. So first we have to remember that not all the cases of systemic lupus erythematosus SLE will present with classical symptoms like classic butterfly rash over the nasal bridge and malar bones. Classic butterfly rash over the nasal bridge and malar bones. Half of them, half of the patients usually present like that. Morning stiffness with polyarticular symmetrical arthralgia is quite commonly seen in patients with SLE. Fatigue and weakness are also common features. In this question, the patient also presents with glomerulonephritis. Because the patient is having microscopic hematuria and proteinuria, so the patient is also having glomerulonephritis. Now, ANCAs, anti-neutrophil cytoplasmic antibodies, these are associated with small vessel vasculitis like Wegener's granulomatosis or Church-Strauss syndrome. Absence of ANCAs cannot indicate the absence of disease, but it gives us a clue of which are the less likely options. We already saw SLE before. In SLE, important must-know features are first, remitting relapsing illness, mouth ulcers which are large, multiple and painful, lymphadenopathy, malar or butterfly rash sparing nasolabial folds, discoidal rash in sun-exposed areas, photosensitivity, arthralgia. Arthritis and arthralgia frequently involve wrist and small joints of hands. Then Raynaud's phenomena. Cardiovascular, we'll see pericarditis. Respiratory, we'll see pleurisy and alveolitis. In renal, we'll see glomerulonephritis detected by proteinuria, hematuria, hypertension, raised serum urea creatinine, neuropsychiatric symptoms like anxiety and depression. Now, other investigations done here are ESR and full blood count. So, ESR is raised, and we will see normochromic normocytic anemia, which is common. Autoantibodies, we will see ANA, anti-nuclear antibodies, which are positive. There's sensitivity of 95%, but not diagnostic in the absence of clinical features because these are non-specific. But anti-double stranded DNA antibodies, these are highly specific but less sensitive. Anti-Smith, highly specific but less sensitive. Anti-histone and rheumatoid factor. Only 20% are rheumatoid factor positive. Now, complement levels C3, C4 are low during active disease because formation of complexes leads to consumption of complements. Now, in case of SLE, ANA, anti-nuclear antibodies, this is the most sensitive test, or it is the most initial test, best screening test. But when it comes to most specific test or most discriminative test, it would not be ANA, it would be anti-double stranded DNA. So in SLE, again, we have to remember remitting, relapsing illness, mouth ulcers, lymphadenopathy, malar butterfly rash, sparing nasolabial folds, discoidal rash in sun exposed areas, photosensitivity, arthralgia, arthritis and arthralgia, Raynaud's phenomena, cardiovascular pericarditis, respiratory pleurisy, and fibrosing alveolitis, renal glomerulonephritis, detected by proteinuria, hematuria, hypertension, raise serum urea creatinine, and the neuropsychiatric symptoms like anxiety and depression. Investigation ESR is raised, and normocytic normochromic anemia. Autoantibodies ANA will be positive, anti-nuclear antibody which is the most sensitive. So most sensitive test, most initial test, and best screening test. But most specific would be anti-double stranded DNA. It would be the most specific and most discriminative, then anti-Smith and anti-histone as well, and 20% of the cases will be rheumatoid factor positive. Complement levels C3, C4 would be low because during the formation of complexes in SLE, these complements are consumed. So ANA is most sensitive, most initial, best screening test. Anti-double stranded DNA is most specific and most discriminative test. And for the management, we will give hydroxychloroquine, NSAIDs, prednisolone, cyclophosphamide. For drug-induced lupus, we will give hydralazine, chlorpromazine, and isoniazid. So management of SLE, we will give hydroxychloroquine, NSAIDs, prednisolone, and cyclophosphamide. Drug-induced lupus, we will give hydralazine, chlorpromazine, and isoniazid. And we already studied that in this case, ANCAs were negative, but it cannot indicate the absence of a disease. It only gives us a clue about what is the more likely option. ANCA indicates small vessel vasculitis, including Wegener's granulomatosis and Church-Strauss. And the main takeaway here is of these symptoms that morning stiffness, polyarticular and symmetrical arthralgia is often seen in patients with SLE. Now we'll take a break here and I'll be back soon. Okay, so let's move to the next scenario. Next, we have a 55-year-old man who developed red tender swollen left foot over the past 2 days. The pain is severe enough that he's unable to wait beer, and he has had a myocardial infarction 4 weeks ago, and he has been diagnosed with heart failure. He was recently prescribed medications by his cardiologist. What which of the medication is likely the cause of his left foot swelling? So this man was likely prescribed diuretic like furosemide to combat the fluid overload from heart failure, and these diuretics like furosemide may raise uric acid levels and may precipitate acute attack of gout. Gout most commonly affects the metatarsophalangeal joint of the first toe, but question writers will not make questions that obvious, and often it may be described as a left foot swelling or along with pain, etc. Although the most commonly involved joint in gout is metatarsophalangeal joint of the first toe. Now, other common precipitants of gout are excessive amounts of alcohol, thiazide diuretics like benroflumethiazide, indapamide, chlorthalidone, metolazone, etc. So, because of heart failure, this patient most probably was prescribed furosemide to combat the fluid overload, and this furosemide may further raise serum uric acid levels, causing hyperuricemia and leading to an acute attack of gout. Let's move to the next one now. 55-year-old woman presenting to the GP surgery with a history of feeling stiff over her neck, shoulders, and hips in the morning over the past 8 weeks. She struggles to get out of the bed, out of her chair since her symptoms started. She finds it difficult lifting her arm above her head. Over the past 3 days, she developed pain in her left jaw on chewing and headache. She is usually fit and healthy on examination. The power of her proximal arms and legs are reduced, and she has tenderness on her left scalp. What is the most appropriate treatment in this case? So this patient presents with features of polymyalgia rheumatica in addition to features of giant cell arteritis. Now both conditions are investigated initially with ESR and managed with prednisolone. Now we have to remember that in polymyalgia rheumatica, it is associated with muscle tenderness, not weakness. In polymyalgia rheumatica, there is pain, no muscle destruction, therefore no elevation of creatine kinase. In polymyositis, there is muscle destruction, hence elevated serum creatine kinase levels. And because of the muscle loss, it leads to weakness as well. So that is the difference between polymyalgia and polymyositis. Now in this case, the patient is having scalp tenderness as well, and patient is having difficulty in lifting her arm above her head, getting out of bed, out of chair, and on examination, the power of her proximal arms and legs are reduced, and she has tenderness on her left scalp. So she presents with features of polymyalgia rheumatica in addition to features of giant cell arteritis. Both the conditions initially investigated with ESR, managed with prednisolone. And we have already studied about both of these conditions. polymyalgia rheumatica as well as temporal arteritis or giant cell arteritis. For polymyalgia rheumatica, ESR should be more than 30, CRP should be more than 6. And polymyalgia, there is pain, not weakness. Muscles are tender, but no true weakness. And long-term prednisolone is given, used for both giant cell arteritis and polymyalgia rheumatica, long-term prednisolone. But it is important to ensure we are managing adverse effects from steroid treatment such as osteoporosis, cataract, GI ulcers, etc. Because they can lead to osteoporosis, demineralization, they can lead to cataract, they can lead to ulcers, gastrointestinal ulcers, so we have to manage that as well. So polymyalgia rheumatica is an inflammatory condition characterized by painful and stiff neck, shoulders, upper arms, hips. And 50% of the patients with giant cell arteritis have polymyalgia rheumatica. And 15% with polymyalgia rheumatica have evidence of giant cell arteritis. So that is a thing over 50 years of age, shoulder, neck, upper arm, pelvic girdle pain. Pain may start asymmetrically, progress to become bilateral, morning stiffness lasting more than 45 minutes. Morning stiffness lasting more than 45 minutes, and the patient is having difficulty rising from a chair, rising from bed, or raising their arms above the shoulder. So that is important. Morning stiffness lasting for more than 45 minutes in polymyalgia rheumatica. Symptoms for 2 weeks or more, and symptoms dramatically improve with corticosteroids. So that is about polymyalgia rheumatica. Quickly, about temporal arteritis or giant cell arteritis, we already studied. It affects large arteries supplying eyes, optic nerve, and head. New onset headache in a patient older than 50 years. And most feared complication is blindness. Clinical features are headache, scalp tenderness, jaw claudication, and decreased vision. Headache, scalp tenderness, jaw claudication, and decreased vision. They may have proximal stiffness of neck, arms, hips, as polymyalgia rheumatica can coexist with temporal arteritis. Investigation initial is ESR, definitive is biopsy of temporal artery biopsy showing characteristic giant cells. Treatment should not be delayed, so because it can lead to permanent vision loss. If ESR is elevated, corticosteroid should be started as soon as possible. Prednisolone used in temporal arteritis, much higher dose as compared to polymyalgia rheumatica. Here 60 mg daily with gradual tapering. In polymyalgia 15 mg daily with gradual tapering. And we can add low dose aspirin as well, like 75 mg daily, to decrease the rate of vision loss and ischemic stroke in patients with temporal arteritis. Let's move to the next question. Next, a 74-year-old woman having 2-day history of right side headache, right scalp tenderness, and pain on chewing. She lost vision in her right eye 20 hours ago. Her ESR is 90. She was subsequently started on high dose oral steroids. What is the single most appropriate investigation? Now, as we already can see that this is a case of temporal arteritis or giant cell arteritis. ESR is often high. There can be transient or permanent vision loss. High dose steroids, prednisolone, are required to reduce the risk of permanent vision loss. They should be started as early as possible when we are sure. And the diagnosis is confirmed. Initial investigation would be ESR, but definitive diagnosis or diagnosis to confirm is temporal artery biopsy. This is a confirmatory diagnosis. Next, a 45-year-old man with severe pain and redness at the metatarsophalangeal joint of his right big toe comes to emergency department never suffered from any form of arthritis before, having hypertension now, was recently started on benroflumethiazide by his GP. What is the single most appropriate management in this case? Now, the diagnosis here is gout, and NSAIDs such as ibuprofen are given for acute attacks of gout. Antihypertensive therapy for this patient will need to be reviewed. Thiazide diuretics raise serum uric acid levels and therefore may increase the risk of subsequent gout attacks, and possible alternatives include calcium channel blockers or sartans, both of which lower serum urate levels. Paracetamol is not effective in the treatment of gout. This is because it predominantly inhibits cyclooxygenase in the central nervous system, therefore lacks the peripheral anti-inflammatory action that NSAIDs produce. So NSAIDs would be useful in this case because they have got peripheral anti-inflammatory action. But paracetamol is not effective in that because paracetamol predominantly inhibits cyclooxygenase in the central nervous system. It predominantly inhibits cyclooxygenase in the central nervous system. And that is why it lacks the peripheral anti-inflammatory action which NSAIDs can produce. Allopurinol is a uric acid lowering drug which is used to prevent gout attack, but it should not be initiated during an acute attack of gout. However, if there is an attack during a course of the drug, it should be continued. So we have to focus on NSAIDs here, such as ibuprofen, which are given for acute attacks of gout. So for management of gout, acute management is NSAIDs, colchicine, intra-articular steroid injection. Chronic hypouricemic therapy, allopurinol, which should not be started until 2 weeks after an acute attack has settled because it may precipitate another attack, and NSAID or colchicine cover. Colchicine cover should be given when starting allopurinol. So diagnosis is by the analysis of synovial fluid. Serum uric acid during the attack may be normal or low. Treatment for acute management, NSAIDs, colchicine, and intra-articular steroid injection. Acute management, acute attack of gout, we will give NSAIDs, colchicine, and intra-articular steroid injection. For long-term hypouricemic therapy, we will use allopurinol, but it should not be started until 2 weeks after an acute attack has settled because it may precipitate another attack. And along with allopurinol, we will have to give a cover of NSAIDs and colchicine. Serum uric acid level is of no value in the diagnosis of acute urate arthropathy. It should only be performed 4 to 6 weeks after the acute attack of gout. Okay, so let's move to the next scenario. Next, a 69-year-old woman with a medical history of rheumatoid arthritis for 25 years presenting with left shoulder pain and swelling for 3 days. She has a low-grade fever. On examination, there is decreased range of motion of the left shoulder joint and movement elicits pain. She takes regular low-dose steroids for the past year to manage her flare-ups of rheumatoid arthritis. She has no known drug allergies. Joint aspiration has been sent for microscopy and culture. CRP is 168, white cell count is 14. What is the single most appropriate management in this case? Now the presentation is in line with septic arthritis, where rheumatoid arthritis is a risk factor. The most important diagnostic test in patients presenting with acute arthritis is examination of the synovial fluid, which was performed in this question already. Empirical treatment should be started in septic arthritis before the results of the culture are obtained, and this empirical treatment involves intravenous flucloxacillin 1 to 2 gram every 6 hours is the most common antibiotic to start with. So IV flucloxacillin in septic arthritis. Now let's study a little more about septic arthritis. The two most common organisms causing septic arthritis are Staphylococcus aureus and Neisseria gonorrhea. Staphylococcus aureus is the most common pathogen for septic arthritis overall. Neisseria gonorrhea is seen in young sexually active adults. Now, most cases of septic arthritis are due to hematogenous spread during transient bacteremia. Most cases of septic arthritis are due to the hematogenous spread during transient bacteremia, but it can also be introduced by a skin lesion which penetrates a joint or by a local spread from contagious infected site. So there are different modes of spread of septic arthritis, but most of the cases of septic arthritis are due to hematogenous spread during bacteremia. But it can also be introduced by a skin lesion which is penetrating the joint or by local spread from a contagious infected site. So risk factors can be prior joint damage, which prior joint damage due to rheumatoid arthritis, gout, or osteoarthritis. It is particularly important to remember rheumatoid arthritis as a risk factor because it is commonly asked. So rheumatoid arthritis, gout, osteoarthritis causing joint damage. This is a risk factor for septic arthritis. Second, immunodeficiency states like HIV and use of corticosteroids. And third, diabetes. These are the risk factors: joint damage due to rheumatoid arthritis, gout, osteoarthritis, immunodeficiency state like HIV and use of corticosteroids, and diabetes. Presentation in septic arthritis would be a single swollen red joint with pain on active or passive movement, restricted joint movement, fever, and rigors. Knees involved in more than 50% of the cases. And we have to remember that there is a triad of fever, pain, and impaired range of motion. Fever, pain, and impaired range of motion. Fever is there. Septic arthritis. Investigation, aspiration of synovial fluid, sent for gram staining, leukocyte count, microscopy, and culture, which is a good pick if the question is asking for the single most appropriate investigation for acute, hot, swollen, painful joint. Second, blood culture, because there is fever in septic arthritis. So most cases of septic arthritis are due to hematogenous spread due to transient bacteremia. So blood culture. Management is flucloxacillin for 4 to 6 weeks. If allergic to penicillin, use clindamycin. If gonococcal arthritis, use cefotaxime or ceftriaxone. If infection is not responding to antibiotics, perform repeated percutaneous aspiration. In general, IV antibiotics are used for 7 days until the swelling subsides and blood culture becomes negative. This is followed by a 4 week course of oral antibiotics. So talking about management of septic arthritis, first is flucloxacillin. We have to remember this: flucloxacillin for septic arthritis for 4 to 6 weeks. It is empirical treatment of septic arthritis. IV flucloxacillin for 4 to 6 weeks. If the patient is penicillin allergic, then give clindamycin. If there is gonococcal arthritis caused by Neisseria gonorrhea, then we will use ceftriaxone or cefotaxime. Ceftriaxone or cefotaxime. And if the infection is not responding to any antibiotics, then we will repeat percutaneous aspiration. Perform repeated percutaneous aspiration. In general, these IV antibiotics are used for 7 days until the swelling subsides and blood cultures become negative, followed by a 4-week course of oral antibiotics. So that is about septic arthritis. Now let's move to the next scenario. A 62-year-old lady has right-sided headache and blurry vision over the past 2 days. She says it started with tenderness on her scalp while combing her hair. Blood test was requested. The results of her ESR has come back elevated. What is the single most appropriate management in this case? So obviously this is a case of temporal arthritis or giant cell arthritis, and we know in that case we have to prescribe corticosteroids. So we have to prescribe prednisolone to the patient because the most common and the most serious complication in this case can be permanent vision loss or permanent blindness. So to prevent permanent vision loss, we have to start the patient on corticosteroids, that is prednisolone, early. When we are seeing ESR to be high, we do not have to wait for temporal artery biopsy. We know initial investigation is ESR, which is high, and we know confirmatory diagnosis or definitive diagnosis is done by temporal artery biopsy, in which we'll see giant cells. But if we are suspecting the patient to be having temporal artery arthritis or giant cell arthritis and the ESR is already high, we have to start prednisolone, corticosteroids as soon as possible to prevent permanent vision loss. So prednisolone should be started when you suspect temporal arthritis. If ESR is elevated, do not wait till you get a temporal artery biopsy. That is a takeaway point here. Next, a 59-year-old man having 4-day history of right-sided headache and decreased blurry vision. He also has pain around his jaw, especially when chewing. He was seen in the hospital and had a blood test which showed elevated ESR. Corticosteroids for a start. What is the single most appropriate medication to be added? Now, we studied about this that low dose aspirin can be added to corticosteroids or prednisolone, that is 75 mg per day, to reduce the rate of vision loss and to reduce the risk of ischemic strokes in the patients with giant cell arthritis or temporal arthritis. So aspirin can be added. Low dose aspirin is increasingly being recommended for people with a history of giant cell arthritis. It is found to decrease the rate of vision loss and risk of ischemic strokes and myocardial infarction in patients with giant cell arthritis. Of course, the most important medication to start for suspected giant cell arthritis is prednisolone. Aspirin is just an add-on. Just an add-on. Yes, and we can also add bisphosphonates to prevent the risk of osteoporosis and demineralization. Next, a 44-year-old woman complaining of sandy feeling under her eyes, which has been present for the last year. She also says she has difficulty in swallowing. On examination, there is bilateral enlargement of the parotid glands, which was noted. What is the single most likely diagnosis in this case? Now, this is a case of Sjogren's syndrome, which we already studied, and we are seeing all the typical features here. We see dry eyes, that is keratoconjunctivitis sicca, patient complaining of itchy eyes, sandy feeling under their eyes because of decreased lacrimal production, dry mouth, difficulty in swallowing of food, vaginal dryness, and bilateral parotid gland enlargement. Parotid enlargement, bilateral enlargement of the parotid glands. Investigation is by Schirmer's test showing decreased tear production, rose Bengal staining showing corneal ulceration. ANA is positive, anti-nuclear antibodies are positive, especially anti-RO and anti-LA. Rheumatoid factor is positive in nearly 100% of the cases of Sjogren's syndrome. Rheumatoid factor is positive. And conservative treatment, artificial tears, artificial saliva, increase intake of fluids. It is an autoimmune disorder. Sjogren's syndrome is an autoimmune disorder affecting exocrine glands, resulting in dry mucosal surfaces. It can be seen alone as primary or secondary, associated with other autoimmune conditions like rheumatoid arthritis, SLE, primary biliary cirrhosis, etc. It can also advance further to involve major organs like lungs and kidneys, and may even evolve into a lymphoproliferative condition like malignant lymphoma. It is more common in females, 9:1 ratio. Next, a 52-year-old woman with a history of systemic lupus erythematosus complains of dry eyes and altered sense of taste. Her voice becomes hoarse when she speaks for long periods of time. What is the single most likely diagnosis in this case? Now, this again is a case of Sjogren's syndrome, and as we studied, it can be associated with other autoimmune conditions like SLE. So it can be present as in a secondary form as well. The patient is complaining of dry eyes, altered sense of taste, and some difficulty in voice. Anti-RO, anti-LA antibodies, and so it is due to the dryness of the throat, which might have led to decreased secretions and leading to hoarseness of the voice. So that can be a possibility here. Next, a 57-year-old pianist presenting to the GP surgery with a painful swelling of his right index finger, and this swelling started 9 months ago. He has had previous stiffness of the joint. At present, he is unable to move the distal interphalangeal joint because of stiffness and pain. He does not take any medications. Picture has been given here, and the picture here shows a Heberden's node. A Heberden's node are typically found in joints as a result of osteoarthritis, and they tend to occur in the distal interphalangeal joint. One of the distractors here is gout, because gout usually occurs more acutely. Now we have to look at the question to compare how gout would present. We have to see that in this patient, the swelling started 9 months ago. So this is not a case of gout. Gout usually presents acutely. It develops within a matter of few days or weeks. Here the swelling started 9 months ago. So this is, and he also had previous stiffness of the joint. So this is not a case of gout. This patient is having Heberden's node here and in his distal interphalangeal joint, and this is a case of osteoarthritis. And rheumatoid arthritis, unlike osteoarthritis, rarely affects distal interphalangeal joint. There is sparing of distal interphalangeal joint in rheumatoid arthritis. We normally use images that we take from a patient with their consent. Okay, there is some note given here. Okay, so yes, rheumatoid arthritis, we will usually there is sparing of distal interphalangeal joints, whereas in osteoarthritis, it frequently involves distal interphalangeal joints. So this is Heberden's nodes, typically found in joints as a result of osteoarthritis, tend to occur in the distal interphalangeal joint, and they don't develop acutely, they take some time to develop, whereas gout usually occurs more acutely. So what we have to remember in osteoarthritis: first, monoarthritis; second, that hip and knee joint are commonly affected. Joint pain is increased or exacerbated by exercise, movement, and it is relieved by rest. So there is history of pain worsening at the end of the day. Sometimes the history can be like that. Bone deformity, there can be some bone deformities due to osteophytes. In fingers, this present as swelling at the distal interphalangeal joint, which is Haberden's nodes, or swelling at the proximal interphalangeal joint, that is Bouchard's nodes. So there are two kinds of nodes which can be seen in osteoarthritis, and Haberden's nodes we can remember as high definition. Haberden's nodes are found in distal interphalangeal joint, and are Bouchard's nodes are found in proximal interphalangeal joints, BP, that is blue picture or blood pressure. So HD and BP. Haberden's nodes, distal interphalangeal joints, Bouchard's nodes, proximal interphalangeal joints. Now X-ray shows loss of joint space, marginal osteophytes, bone cyst, and subarticular sclerosis. So X-ray features would be loss, that is loss of joint space, osteophytes, subchondral cysts, and subchondral sclerosis. Management is exercise, physiotherapy, weight reduction, regular paracetamol, topical NSAIDs, oral NSAIDs such as paracetamol and topical NSAIDs and paracetamol are considered ahead of oral NSAIDs. Oral opioids such as codeine, and joint surgery as the last option. Prescribe paracetamol if not already using it. If at a risk of gastric ulcers, do not use NSAIDs unless there is absolutely no better option. Then pick celecoxib with a proton pump inhibitor, alternatively pick codeine. So talking about osteoarthritis, features are first it is monoarthritis, second hip joint and knee joint are commonly affected, and joint pain is increased or exacerbated by exercise and movements, and it is relieved by rest, unlike rheumatoid arthritis. And bony deformities can be present due to osteophytes. Some bony deformities can be present due to osteophytes, such as in fingers. This presents as a swelling at the distal interphalangeal joints, that is called as Haberden's nodes, and swelling present at the proximal interphalangeal joints called as Bouchard's nodes. HD and BP, Haberden's nodes, distal interphalangeal joint, Bouchard's nodes, proximal interphalangeal joints. Now, X-ray finding of osteoarthritis would be X-ray findings of osteoarthritis can be remembered as loss, that is first loss of joint space, then O for osteophytes, then S for subchondral cysts, and S for subchondral sclerosis. So X-ray features of osteoarthritis: loss, L for loss of joint space, O for osteophytes, S for subchondral cysts, and S for subchondral sclerosis. Subchondral cysts and subchondral sclerosis. Now, talking about management. Management involves exercise, physiotherapy, weight reduction, regular paracetamol, NSAIDs, oral NSAIDs, first topical NSAIDs, then oral NSAIDs, then oral opioids. Opioids such as codeine can also be given, and joint surgery is the last option. If risk of gastric ulcers, then we have to use NSAIDs very carefully. Unless there is absolutely no better option, then pick celecoxib with a proton pump inhibitor. Or alternatively, we can prescribe codeine, opioids like codeine. Okay, let's move to the next scenario. A 38-year-old male presenting to his GP with a complaint of coughing up blood. He says that he coughed up a few droplets of blood twice in the past 3 days and that he was concerned. Further questioning also reveals that he has been suffering from fatigue, malaise, generalized joint pain for about 3 months now, and he takes over counter paracetamol for his aches and joint pain. He has been suffering from chronic sinusitis, has been treated with several courses of antibiotics in the past. On examination, there is crusting in and around the patient's nose. A urine dipstick done shows the presence of blood. What is the single most likely diagnosis in this case? Now, this is a case of Wegener's granulomatosis, that is granulomatosis with polyangiitis. The patient has granulomatosis with polyangiitis, also called as Wegener's granulomatosis. There is usually an upper respiratory tract component, lung component, and kidney component. Here, the upper respiratory tract component is the chronic sinusitis. Here, upper respiratory tract component is chronic sinusitis and crusting around the nose. Lung component is hemoptysis, and lastly, the kidney component is hematuria. So there is blood from nose, from mouth, as well as through urine. So through all these three passages, we see bleeding happening, passing of blood. So upper respiratory tract component, lung component, that is lower respiratory tract component, upper respiratory tract component, lung component, and kidney component. Upper respiratory tract component here was chronic sinusitis with crusting around nose. Lung component was hemoptysis, coughing of the blood, and kidney component was hematuria. Granulomatosis with polyangiitis or Wegener's granulomatosis is easy to spot because they present with clinical features involving different symptoms. But the question would usually include specific points surrounding the nose, such as crusting around the nose or a characteristic saddle shaped nose, etc. Crusting around the nose, saddle shaped nose, blood from lungs and kidneys, and CA. So, yes, that will point towards granulomatosis with polyangiitis or Wegener's granulomatosis. Upper respiratory, we will see nosebleed, crush around nostrils, chronic sinusitis, saddle nose deformity, bloody rhinorrhea. Lungs, we will see hemoptysis and cough. Kidneys, we will see hematuria. So this granulomatosis with polyangiitis, also called as Wegener's granulomatosis, is an idiopathic small to medium vessel vasculitis appearing around middle age. Upper respiratory tract, lungs and kidneys, and CA and CA. Here CA and CA will be positive, whereas PA and CA is positive in Churg-Strauss syndrome, which is eosinophilic granulomatosis with polyangiitis or allergic granulomatosis with polyangiitis. So PA and CA is positive in Churg-Strauss syndrome, which is eosinophilic granulomatosis with polyangiitis, and CA and CA is positive in granulomatosis with polyangiitis or Wegener's granulomatosis, CA and CA, which is anti-neutrophilic cytoplasmic antibodies. Treatment is not included here, is beyond the scope of this exam for now. Next, a 27-year-old man has recurrent lower back pain and stiffness. The pain is worse in the morning, improves when he exercises. He finds it difficult to bend his back. It has been gradually worsening over the past 6 months. He has no history of trauma to his back. What is the single most appropriate investigation to perform? Now, this is a case of ankylosing spondylitis, and X-ray of the sacroiliac joint is the most useful investigation here. So, X-ray of the sacroiliac joint is the most useful investigation. It would show evidence of sacroiliitis, which is the earliest finding. Later findings, once there is significant chronic spine inflammation, would include a bamboo spine and squaring of the vertebral bodies. ESR levels correlate with disease activity and is a good blood test to order when thinking about ankylosing spondylitis. But an X-ray is still a better test to perform to diagnose ankylosing spondylitis. HLA-B27 should not be used to diagnose ankylosing spondylitis because it can be present in many different conditions. MRI scanning has a growing role in diagnosis and prognostication. MRI of the sacroiliac joints are considered to be more sensitive than a plain X-ray or CT scan in demonstrating sacroiliitis. We can also use unenhanced MRI of the back if X-rays are seen to be normal. So, X-ray of the sacroiliac joint is the most useful investigation in ankylosing spondylitis because it will show the evidence of sacroiliitis, which is the earliest finding, and later findings once can be found, like if there is significant chronic spine inflammation. We can find bamboo spine. We can find features like bamboo spine and squaring of vertebral bodies if there is significant chronic spine inflammation. Then there can be bamboo spine and squaring of vertebral bodies. ESR level would be high, correlating with the disease activity. Good blood test to order. But X-ray is still a better test to perform to diagnose ankylosing spondylitis. HLA-B27 is not a good test or should not be used to diagnose ankylosing spondylitis. MRI scanning has a growing role in diagnosis and prognostication. MRI of sacroiliac joint more sensitive than plain X-ray or CT scan in demonstrating sacroiliitis. Young man before the age of 30 presenting with lower back pain, stiffness which is worse in the morning, improves with exercise, strong association with HLA-B27, tenderness of sacroiliac or limited range of spinal motion. It is a type of HLA-B27 associated spondyloarthropathy which primarily involves the axial skeleton, that is sacroiliitis and spondylitis. Sacroiliitis and spondylitis. This is about ankylosing spondylitis. Test is Schober's test. We draw a line 10 centimeters above, 5 centimeters below the back dimples of Venus. The distance between these two lines should increase by more than 5 centimeters when the patient is bending forward as much as possible. This is Schober's test for ankylosing spondylitis. Other features are anterior uveitis and aortic regurgitation. Anterior uveitis with presenting with painful red eye and severe photophobia, and aortic regurgitation. Plain X-ray of sacroiliac joints is the most useful test, most helpful test in ankylosing spondylitis. Do not use HLA-B27 as it is also positive in 10% of normal patients. Management: first line NSAIDs, second line anti-TNF therapy. First line is NSAIDs, second line is anti-TNF therapy. It's about ankylosing spondylitis. So seronegative spondyloarthropathy, in which rheumatoid factor is negative, can be remembered as PEAR, that is psoriatic arthritis, enteropathic arthritis, ankylosing spondylitis, and reactive arthritis. and they are associated with HLA-B27. Ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic arthritis. These are seronegative spondyloarthropathies. Peer, seronegative spondyloarthropathy, psoriatic arthritis, enteropathic arthritis, ankylosing spondylitis, and reactive arthritis. Okay. Associated with HLA-B27 and rheumatoid factor negative. So seronegative. Next, a 15-year-old boy was referred to the medical team with painful joints and a rash. The pain initially started on both the sides of his knees a few days ago, progressed to his ankles and elbows. Ibuprofen seems to help with the pain in his joints. He had a sore throat, a fever 2 weeks ago, which has resolved on its own. On examination, a pansystolic murmur can be heard in the mitral area. There are pink annular rashes on the trunk, upper arm, and legs. Blood tests were taken and sent to the laboratory. What is the single most likely laboratory value to be abnormal? Now, in teenagers suffering from rheumatic fever, the large joints of the lower limbs, such as the knee joint, are first to be affected. Arthritis will normally migrate to large joints such as ankles, elbows, and wrist. It is mild and tends to resolve in 2 to 4 weeks. Mitral valve is the most commonly affected valve in rheumatic heart disease. It is much more commonly affected than the aortic valve. And rheumatic fever can result in mitral regurgitation and mitral stenosis. In this question, a pansystolic murmur makes mitral regurgitation the likely valve defect. Skin manifestation in this question is called erythema marginatum, which involves pink rings on the trunk and inner surfaces of the limb. And it is clear that this boy is suffering from rheumatic fever. But the choice of ESR and anti-streptolysin O is always a difficult one, as both can be elevated in rheumatic fever. Anti-streptolysin O antibodies tend to peak around 4 weeks, which is usually around 2 weeks from the time they develop clinical features like arthritis or erythema marginatum. For that reason, it is useful to do serial ASO titers every 14 days. A serial rise of ASO titers is supportive of the diagnosis. Ultimately, ASO titers are a good test to request for someone you suspect has a rheumatic fever, but it can be negative up to 20% of patients who have acute rheumatic fever. Now, ESR and CRP levels are elevated early in the disease process. And these are useful in monitoring the disease. It is highly unlikely that ESR would be normal in a patient with acute rheumatic fever. In summary, ASR is more likely to be abnormal compared to ASO. However, ASO is more specific than ESR. So if the question asks, what is the most appropriate investigation? Pick ASO. What is the most specific laboratory test? Pick ASO. What is the most likely laboratory value to be abnormal? Then we have to pick ESR for rheumatic fever. So let's study about rheumatic fever a little more. Rheumatic fever is a delayed inflammatory response which develops 2 to 4 weeks after a streptococcal throat infection. The inflammatory response results in arthritis, damaged heart valves, that is rheumatic heart disease, then involuntary muscle movements, Sydenham's chorea, and dermatological manifestations. Arthritis, in this arthritic pain is usually more severe in teenagers. It starts in large joints of the lower limbs such as knees and migrates. Cardiac disease, rheumatic heart disease is the most severe outcome of acute rheumatic fever, and it results in valvular heart disease. Involuntary muscle movements. Sydenham's chorea, which consists of abrupt movements, usually involving the hands and face, is a manifestation and can sometimes be seen months after the initial infection. Dermatological manifestations. Skin manifestations include subcutaneous nodules on bony surfaces and erythema marginatum. So, skin manifestations include subcutaneous nodules on bony surfaces and erythema marginatum. The diagnosis is based on the revised Jones criteria. Now, revised Jones criteria requires two major or one major and two minor criteria. Major manifestations are carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. Minor manifestations are fever, arthralgia, previous rheumatic fever, or rheumatic disease. Then, in laboratory tests, raised ESR or CRP, raised ASO titer, peaking usually at 4 weeks, positive throat culture for group A streptococcus. An echocardiogram is an important part of the investigation. Now, treatment. Penicillin, even in the absence of pharyngitis. Second, anti-inflammatories. Third, penicillin prophylaxis can be given until age 21 at least. So, coming on to rheumatic fever is a delayed inflammatory response which develops 2 to 4 weeks after a streptococcal throat infection. And the inflammatory response results in arthritis and damaged heart walls, causing rheumatic heart disease or valvular heart disease, and involuntary muscle movements, that is Sydenham's chorea, and dermatological manifestations. So, arthritis, we will see arthritic pain and usually involving large joints of the lower limb, such as knee, and it migrates as well. Cardiac disease, we will see rheumatic heart disease, which is the most severe outcome of acute rheumatic fever, which results in valvular heart disease. Then we'll see involuntary muscle movements, that is Sydenham's chorea, consisting of abrupt movements involving the hands and face, which is a manifestation sometimes be seen months after the initial infection. Sydenham's chorea is consisting of abrupt movements of hands and face, which is a manifestation of rheumatic fever. Can also present months after initial infection. Now, dermatological manifestations. Skin manifestation will include subcutaneous nodules on bony surfaces and erythema marginatum. Subcutaneous nodules on bony surfaces and erythema marginatum. These are the dermatological manifestations. Now, talking about the diagnosis of rheumatic fever, which is based on revised Jones criteria. Now, talking about Jones criteria, we will have it requires two major criteria or one major and two minor criteria. Now, what are the major and minor criteria? Major criteria are carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. And minor manifestations are fever, arthralgia, and previous rheumatic fever or rheumatic heart disease. Then, so minor manifestations, fever, arthralgia, previous rheumatic fever or rheumatic heart disease. So these are the minor manifestations. Three: fever, arthralgia, previous rheumatic heart, previous rheumatic fever or rheumatic heart disease. And major manifestations are carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. And we need two major or one major and two minor criteria according to revised Jones criteria for the diagnosis of rheumatic fever. Laboratory test: raised ESR or CRP, raised ASO titer, which peaks at around 4 weeks, and positive throat culture for group A streptococcus. So raised ESRs, raised CRP, and raised ASO titer peaking at 4 weeks, and positive throat culture for group A streptococcus bacteria. An echocardiogram is also an important part of the investigation. Now, treatment. Treatment: penicillin, even in the absence of pharyngitis, anti-inflammatories, and penicillin prophylaxis can be given until age 21 at least. So, here we can see the revised Jones criteria used to diagnose acute rheumatic fever. Evidence: the diagnosis requires two major criteria or one major plus two minor criteria. Along with that, evidence of recent streptococcal infection. Recent streptococcal infection. Major criteria are polyarthritis, carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Minor criteria: fever, arthralgia, previous rheumatic fever or rheumatic heart disease, raised ESR or C-reactive protein, prolonged PR interval on ECG. Okay, so there are five major and five minor. Five minor criteria are fever, arthralgia, previous rheumatic fever or rheumatic heart disease, raised ESR or CRP, and prolonged PR interval on ECG. Again, revised Jones criteria is used to diagnose rheumatic fever. For diagnosis, we require evidence of early evidence of recent streptococcal infection plus two major criteria or one major plus two minor criteria. Major criteria: five major criteria, five minor criteria. Five major are carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. And five minor criteria are fever, arthralgia, previous rheumatic fever or rheumatic heart disease, raised ESR and CRP, and prolonged PR interval in ECG. Rheumatic fever, we already studied. Inflammation post streptococcal throat can result in, these are the manifestations: arthritis, rheumatic heart disease, chorea, and skin manifestation. And this is the investigation. Throat culture for group A streptococcus will be positive, and echocardiogram is also important. For investigation, ESR and CRP would be high, ASO titer would be high, peaking at 4 weeks, and throat culture for group A streptococcus will be positive, and echocardiogram. ESR is more sensitive than ASO, but ASO is more specific than ESR. That means if a question is asking which is more likely to be abnormal, ESR is more likely to be abnormal when compared to ASO. Treatment is with penicillin. Penicillin even in absence of pharyngitis. Anti-inflammatories with penicillin. So it is a delayed inflammatory response which develops 2 to 4 weeks after a streptococcal throat infection. So this is about rheumatic fever. So ESR and CRP levels are elevated early in the disease process. So if the question is asking most appropriate investigation, it would be ASO titer, most specific laboratory test ASO, but most likely laboratory value to be abnormal ESR, not ASO, because it can be negative in up to 20% of the patients who have got acute rheumatic fever, ASO titer, although it is more specific. And it peaks at around 4 weeks, which is usually around 2 weeks from the time they develop clinical features. So ASO titer should be done every 14 days. Next, a 35-year-old woman, a 35-year-old man who has recently been diagnosed as having asthma, attended clinic with complaints of having deep and aching pain in his lower back, especially at night for the past 6 months. His medical notes include having a nasal polyp removed by ENT 3 years ago, also suffers from allergic rhinitis. There are skin lesions present in the form of tender subcutaneous nodules on his legs. Investigations were performed and he was started on corticosteroids. Now, what is the single most likely diagnosis in this case? The features of asthma, allergic rhinitis, nasal polyps, and skin nodules are consistent with Churg-Strauss syndrome despite the rarity of it. We have to remember the criteria, the 6 criteria for the diagnosis of Churg-Strauss syndrome given by American College of Rheumatology. That is asthma. First, what is Churg-Strauss syndrome? It is a rare diffuse vasculitic disease affecting coronary, pulmonary, cerebral, abdominal, visceral, and skin circulation. Cardinal manifestation of Churg-Strauss syndrome include asthma, eosinophilia, and lung involvement. This is the cardinal manifestation of Churg-Strauss syndrome or eosinophilic granulomatosis with polyangiitis. Here we'll see asthma, eosinophilia, and lung involvement. Now, the 6 criteria for the diagnosis of Churg-Strauss syndrome are asthma, eosinophilia, paranasal sinusitis, pulmonary infiltrates, vasculitis, and polyneuropathy. Presence of 4 out of these 6 features is used for diagnosis of Churg-Strauss syndrome. We can have pulmonary symptoms like asthma, upper respiratory tract like allergic rhinitis, paranasal sinusitis, nasal polyposis, cardiac features like heart failure, myocarditis, myocardial infarction, skin features like purpura, skin nodules, and renal features like glomerulonephritis, and last, peripheral neuropathy. So, asthma, eosinophilia, paranasal sinusitis, pulmonary infiltrates, vasculitis, and polyneuropathy. Asthma, eosinophilia, pulmonary infiltrates, paranasal sinusitis, and vasculitis and polyneuropathy. These are the 6 criteria given by American College of Rheumatology for diagnosis of Churg-Strauss. 4 out of 6 will be having high specificity and sensitivity for the diagnosis of Churg-Strauss. Presentation: pulmonary asthma, upper respiratory tract allergic rhinitis, paranasal sinusitis, nasal polyposis, cardiac, heart failure, myocarditis, myocardial infarction, skin nodules, purpura, glomerulonephritis, and peripheral neuropathy. Investigation: ANCA. We know in this case PANCA will be positive. These are the anti-myeloperoxidase antibodies, anti-neutrophil cytoplasmic antibodies, raised ESR and CRP, eosinophilia and anemia, increased serum IgE levels, chest X-ray showing pulmonary opacities, pulmonary infiltrates, multifocal consolidation. CT scan, we'll see ground glass attenuation. Biopsy, we'll see small necrotizing granulomas and necrotizing vasculitis. So this is about Chuck Strauss. Next, a 26-year-old avid badminton player presenting to GP surgery with a gradual onset of pain in her wrist that is exacerbated by gripping and raising objects. On examination, she has normal wrist motion, some tenderness over the radial styloid process. The pain is exacerbated on ulnar deviation when the thumb is gripped with the fingers of the affected hand. What is the most appropriate diagnosis? So this is a case of D. curvans tenosynovitis. It is diagnosed clinically by two tests, Finkelstein's test and Eichhoff's test. Eichhoff's and Finkelstein both are positive if pain is felt over the tip of the styloid process, which is towards the radial side of the wrist, towards the thumb side of the wrist. So on ulnar deviation of the hand, pain is elicited over the tip of the styloid process. So in that case, both Eichhoff's test and Finkelstein's test, these are positive. Trigger finger is in the adult. Trigger finger in the adult is due to a nodular thickening of the flexor tendon. Now these are the differentials. Trigger finger in the adult is due to the nodular thickening of the flexor tendon. Patient presenting with difficulty in extending a flexed finger where it snaps once it passes an obstruction. That is trigger finger. It is due to nodular thickening of the flexor tendon, and the patient presents with difficulty in extending a flexed finger where it snaps once it passes an obstruction. Carpal tunnel syndrome presents with findings like wasting and paresthesia along median nerve distribution areas. And tennis elbow involves the elbow. Dipterin's contracture causes skin thickening, tethering, puckering, pitting, dimpling over the palm with firm nodules fixed to the skin and deep fascia of the palm or fingers. So this was about rheumatology, and from the next session we will move on to the next topic. Take care, and I'll be back in the next session.